Good morning, everyone. Welcome to Carilion Children's Pediatric Grand Rounds. Today's speaker is Dr. Richard Cordle. Dr. Cordle grew up and graduated high school from Richmond, Virginia. He went to undergrad at UVA and WashU in St. Louis for medical school and fellowship. He completed his residency at Wilford Hall Medical Center in United States Air Force in San Antonio, Texas. After fellowship, he returned to the Air Force in San Antonio and served on staff there as a pediatric gastroenterologist with the San Antonio Military Pediatric Center during the 911 era. In 2002, Dr. Cordle returned here to Carilion, where pediatrics was based at Community Hospital, and way before there was a med school and a Starbucks, but the light bulb was invented at that time. He thinks it's been exciting to be part of the changes in our local community, and he now serves as a section chief of pediatric gastroenterology. While not busy in practice, he focuses on his family, which has spread far and wide: Mississippi, Nashville, Miami, Washington, D.C., Wilmington, and Pittsburgh. Please join me in welcoming Dr. Richard Cordle.
Thanks to those who got up early. So this title, Learning About the Changing and Growing Understanding of a Relatively Young Disease, when you think about diabetes perhaps becoming detected in the early 20th century, you think about learning what influenza was about that same time, and then you think about eosinophilic esophagitis being actually in my lifetime and bookends my career. So it's exciting to me to watch the change, and so we're going to learn about how it's we still see things the way we did when it started, but there's been a lot learned since that time. So these are the objectives. So first this all centers around how you make the diagnosis. So the first thing is, how do we recognize somebody with EOE? The second thing is then, how do we formally diagnose it, which is by endoscopy? And then, and so what that looks like. And then learn some of the treatment. There's 5 treatment arms that we can offer, one of really 4 that we can offer. And then realize that this is a lifelong disorder and that it needs long-term monitoring. So that's kind of the themes we're going to go over. Undergirding all this is the definition. So this is any paper that you see, usually this is the first line. So eosinophilic esophagitis is a chronic allergen-induced type 2 mediated, Th2 mediated disease of the esophagus. It's an immune disease characterized by symptoms of esophageal dysfunction. You're going to hear that term. That just means swallowing, eating, functioning, and a eosinophilic predominant infiltrate in the esophagus. So when it was first discovered, which was in the 90s, incidence was and prevalence was low, and you can see over the 3 decades it has really grown. So 5-fold increase since 2009. A recent evaluation of the prevalence showed that it was as high as 1 in 700. And so if you compare to a recent survey of the prevalence of type 1 diabetes in youth in this country, which is 3.5 in 1,000, EOE is about half that. So becoming very common. You can see it's not a U.S. disease, it's international, and that the prevalence is also increasing internationally from 8 in 100,000 back in the early 2000s all the way to 74 in 100,000 today. This is another picture of that. Here's my mouse. I don't know if you can see the mouse, but this is looking at insurance data and also Medicare data. So the top 3 graphs are insurance data. There he is. Hey, Mike.
Sorry, stuck on 460.
Good to see you. This is my mentor, Dr. Hart. So good to see him. So taught me everything I know. So this is looking at insurance data over time. So you can see this is like kind of 0 to 65. This being kind of the youth, since 65 is still youthful. So the These are 3 different epochs over time, and you can see from 2009, 2015, 2022, it's just mushroomed, the increased prevalence of EOE. This is Medicare data also, and you can see similar timeframes, even in the elderly, that it's going up. But maybe it's going up because we're getting more aware of it, and we're looking for it more. Maybe that's the reason. And so one look at that in Denmark showed that over almost a 2-decade time, the EOE increased 19.5-fold, but really the number of biopsies being obtained only went up 2-fold. So you can't, yes, it's somewhat from increased surveillance and awareness, but it's also just mushrooming in terms of its frequency. This is a little, if you go and do a PubMed and you look at the number of articles that are occurring over time, you usually get a little graph on the side. Almost every disorder looks kind of like this, but look at how much it's mushroomed. And so this is sort of the beginning and the end. This is kind of like my career. And I would like to think this is what's happening in my mind over time. But I think this over here is more what's happening, that little drop off. But you can see that our understanding of EOE over time has really also exploded. And so we are much more aware. And so I thought it would be interesting and almost like a story to kind of take us back to 1993 when this was coming out. And we start to get some kind of a, it'll be like a way of introducing the disorder to us. And we see some of the clinical features and the way that we make the diagnosis back then still kind of hold over to today. I love this kind of thing because it takes creativity to start saying, we're seeing something different. And I encourage you who are just starting your career that if you start to see things that are just not fitting the norm, shelve that, start thinking about that. And it could be a research protocol in the future or something that a question that you'd like to answer. So the first, this is a radiology journal. This is back in 1993. And so some of you weren't born yet. They reported that before 1993, only 10 cases were seen. And they called it idiopathic esophageal eosinophilia. So they had, they reported a series of cases also. This line doesn't make sense, but they reported 13 cases. All had dysphagia, trouble swallowing, and they did radiology with them, hence it's in a radiology journal, and they showed these strictures. Now these strictures are not like peptic strictures, they were very different. They also, here's the 10 of 13, they also noticed that they all frequently had an atopic history, be it allergic rhinitis, food allergies, asthma, atopic dermatitis. Then they also noticed it was an inflammatory disorder. They all responded to systemic steroids. So they gave these people steroids. Let me just show you some of these pictures. This is, sorry, I was just highlighting some of those interesting things that we're seeing. So I put this in here just to show you what a normal barium swallow would look like. You can see the esophagus is not a passive organ. It doesn't just sit there and let things go through. It dilates and then it squeezes behind it. So it has to be expansile or distensible. And so you can see in this normal case, it was distensible. The contrast goes down. This is an example of a peptic stricture, kind of what you would expect with somebody who's had reflux over a long time. You can see right in this area at the distal esophagus, a shouldering of the esophagus at that point. However, I think anybody can see that these are different. And so this is from that journal article, and you can see these long strictures that have developed in these cases. And this is a picture of what they look like after they treated them with steroids. So clearly, using steroids seemed to help them to gain some diameter length back. But what is happening here? There's something different, unique, that people started to recognize. Another paper at the same time called this a new clinicopathological entity. And they had 12 patients. They noticed in their biopsies a dense eosinophilia, more than what you would see with something else like reflux. They did pH probe monitoring, found that they weren't seeing acid in these people. And then they compared these to those with known reflux that never totaled this amount. So, and so that's when they proclaimed that this was something new, something different that they were seeing. Then over time, papers started coming out saying, what are we seeing here? And they started to document some of the endoscopic findings. And this is an exudate that you see lining the esophagus of these patients. What you don't see here also is you don't see vascular markings. And that's also clear here. See how it's kind of pale? That's called edema. And you don't see the vascular markings that you typically do. You see these garden rows or furrows that are going down. They used to be called vertical lines of the esophageal mucosa, or VLEMs, back in the early 2000s. And then also trachealization. So you can see these rings that develop. This is very peculiar. We don't see this very commonly in children, but this is an advanced presentation, and you can see these rings, and they often lead to strictures. So this is a narrowing of the esophagus that probably will not allow the scope to go by without doing something else. The other thing that was noticed is that the lining of the esophageal mucosa was fragile. It would tear easily just with passing the scope by. And this is a scope I did in June. And you can see this is my first peek at the guy coming in. So this is some of those furrows, kind of very interesting furrows. And I just walked by. I was just dilated the esophagus. That's all going with air. And you can see it's already starting to bleed. So the mucosa is very fragile. Here's some other examples of that. And you can see these are quite dramatic. And this is just a scope going by, tore the esophagus in two places. Here's another tear. Not something that you like to see, that when you're doing endoscopy. So we do biopsies, and then back in the early 2000s, started to be able to qualify what is it that we're seeing under the microscope. And so not only you can see the little eosinophils. Eosinophil means lover of red. So there's a red dye that you see in this area. You can also see this elongation of all these white cells in this basal zone hyperplasia in here. And then over here you see this grouping, this clumping of eosinophils at the top of the esophageal mucosa. This is surface layering, or this grouping is called microabscess. So these are just some histological changes. So we've seen what was clinically happening. We've seen radiology changes. We've seen endoscopic changes. We're seeing pathological changes. Also, what's going on? Why are they stiff? Why is it so easy to shear these? And this is early. This is in the early 2000s. This is endoscopic ultrasounds done in Boston. And you can see this is the normal case. This is what the wall looks like normally. And then you can see these thickened, the walls thickened in these cases. And then you can see these longitudinal thickenings. Perhaps this is the furrows that we're seeing. Perhaps from swelling in the lining of the mucosa. Okay, so what are we going to do with these patients? How can we approach them and treat them? So this is a landmark paper. In fact, there's actually another gastro article that came out, I think in 2020, talking about the 25th anniversary of this paper. And so this is what I'm talking about being creative and thoughtful. And so this guy was at Johns Hopkins, and he got a group of patients referred to him with refractory reflux. So these are people that, there's 10 patients. They'd been tried on medication, 6 of them, so let's move on. The 6 of the 10 had fundoplication, and they still were not responding to therapy. So they also biopsied and noticed that they had a host of eosinophils. And since 1982, eosinophils in the esophagus were considered abnormal. So you shouldn't see them in the esophagus, and when you see them there, you typically think reflux. And so they were thinking along the paradigm of reflux. And so here's refractory reflux. Why are they not responding to therapy? And then he noticed that they had all these increased eosinophils. And so the hypothesis was that this wasn't reflux, but that it was actually something new, different, that it was a hypersensitivity. Interestingly, they had some symptoms of reflux. These are all things, but they had some different things. They called it profound disinterest in eating, PDIE, and which I don't understand, profound disinterest in eating. I have a profound interest in eating. That's PIIE. So then there's abdominal pain, there's vomiting, and then they would have this mucus. And I've actually had patients talk to me about they had this thick mucus that in their throat but in this paper they called it uncooked egg whites. And you remember I showed you that picture of exudate on the lining of the esophagus, possibly that. So here's a tabulature table of the patients, the 10 patients, and you can see their age ranges throughout children. These are children that the average was 5. And you can see most of them are not eating well. Some of them not gaining weight. And I thought that was very, tuck that in the back of your mind. Interestingly, the majority had atopic symptoms, like we were talking earlier. So something allergic, something inflammatory is happening. So what they decided to do, since the theory is that maybe this is a food allergy, maybe there's something exposing to the esophagus that is leading to this. So that was the hypothesis, that it wasn't reflux, that it was something else. So they took 10 children and they put them for 6 weeks on an elemental diet. So that's all they could do is this, and some of these kids are teenagers, so 12-year-olds, all they could drink, all they could eat for 6 weeks. I don't know how they signed them up. They must have bought them something. But anyway, 6 weeks of eating this stuff, and if you've ever smelled, some of the amino acid, this was neocate. It's like potato water. So 10 of them responded. So they got 8 of the 10 to agree to a follow-up endoscopy, and they showed that the average eosinophil count dropped from 41 per high-powered field to 0.5. So significant improvement underneath the microscope, but all 10 had symptom improvement. This is the type of food, when they started to introduce foods back, these are the things that they found that they were mostly sensitive to. So remember that, tuck that away, because in time, that's going to be also very important. So after the first decade of knowing about this disorder, we knew that these patients who had EOE had dysphagia, often had a refusal or fear of eating. It was demonstrated that was related to food allergens and showed that this was distinct from reflux, as was just seen. And so this kind of prepared the way for intervening in these patients and really kind of prepared the roadmap for how we were going to handle EOE. It was mostly dietary, maybe anti-inflammatory treatment in time. And so what kind of people so this is like, what are the risk factors for getting EOE? And one is having atopic symptoms, as I mentioned. There's also possible environmental exposures. There's people who can also have genetic predisposition to EOE. And then also it's seen with other autoimmune disorders like celiac, connective tissue disorders, and Crohn's. So this is just to bring out the atopic nature. So typically about 70% of patients will have other atopic disorders. And this was seen in this paper looking at both children and adults, just showing that it could be allergic rhinitis, asthma, other food-related allergies, or even eczema. But what about other life exposures? So one paper showed that maybe there was an increased incidence in urban settings in New England. But this is a heat map showing incidence. So this is down here to understand this graph, this table is odds ratio of having EOE. And you can see very hot here in the mountain time zone. And what's unique to that area, sparsely populated, more arid, it's hard to know. But there's definitely, what are they being exposed to? And there's definitely a seasonal predominance. You'll actually see more cases of EOE during the allergen season, although the last time I was on call, we're going to see all 3 of those cases today. I'll show up here, I had 3 cases that were very illustrative, interestingly, of all this stuff. And then, interestingly, they took mice, this is back in 2001, they took mice, laid them on the table, and they put in their nostrils so they would breathe in aspergillus, and they realized that they showed that this was generating EOE in their esophagus. So interestingly, sometimes there's something in the air that kind of comes with the food, maybe it's on the food, like pollen perhaps, that is leading to some of this. Other life exposures are interesting to think about. We're not going to dwell on this too long, but you can see there's, in adults, maybe, because this is all still speculative, higher incidence perhaps with H. pylori infection, NSAID use, antibiotics younger in life. Interestingly, if you smoke, you don't have EOE, so children, if you're higher incidence, if you've had some birth-related historical features or even acid suppression in infancy may lead to increased incidence of EOE later. So lower if you are breastfeeding or if you have a little dog or cat in your house or something. So when they're first born. Couldn't find a picture of my grandson with the dog last night in time. So then they looked at family history, looking at Utah population database with genealogy resources. It's interesting, this was odds ratio of you having EOE with first degree relatives. So anything high positive is going to means higher incidence. So you can see that first degree relatives is a huge increase, even second degree relative cousins. But this is really interesting. If your spouse has EOE, so that's not even genetically related. Well, it shouldn't be. So I know where you come from. Sorry, always have to get a dig in. So the spouses are usually not related, but it's interesting that there might be something that you're exposed to also. Sorry, I can resist. So this is I just found this online. This is a great summary slide. It's helpful when you think about the family history. Are there some genes that are there some things that you're born with that make you more prone to having EOE? Interestingly, the problem is not the eosinophil. So if you expose patients to something called benralizumab, which is a monoclonal antibody to IL-5, is right here. IL-5 is involved with recruitment, but also effects from the eosinophil, and there's still, the eosinophils are annihilated. So you go back and look, they're gone. All the eosinophils are gone. They still have stiffness, they still have dysphagia. This is animal models. They still have dysphagia, you haven't fixed it. So it's not the eosinophil. There's something wrong with the barrier, actually. And so there's some, this is called thymic stromal lymphopoietin. If you have, there's been mutations in this, and also in these serine protein inhibitor, Sol type, so Spinks. So these things help these, this is a protease inhibitor. So if your proteases run wild, they're gonna start destroying the barrier. Also, acid being exposed might be also something that destroys the barrier and allows the antigen to get into the esophagus. So once that happens, the TSLP kind of brings and stimulates the T cells. T cells then start elaborating IL-4 and 13, which then, this is actually eotaxin 3. They turn on eotaxin 3, which calls their eosinophil buddies into the esophagus, and then it just proliferates, and then that causes the swelling, but also the eosinophil will start to elaborate, transforming growth factor B and fibroblasts, start laying down scar tissue, and that's important also. So that scar tissue over time is what's important to the EOE. So this is going to be important to think about also when we think about therapy. Where can we target things in therapy and how do we approach these? Because it's really been a radical shift of how we approach the diagnosis. So here are the diagnostic guidelines from a recent 2025 guidelines paper, just showing that the first thing that you do to make the diagnosis is having clinical evidence of esophageal dysfunction. We're going to spend a few moments on that. And then about the endoscopic evaluation of it and how we go about that. And then briefly on just think about other things that could cause eosinophils to come into your esophagus. So this is sort of how we approach things. But this is different from the 2011 guidelines. There's something missing. So what is missing? So this is just showing you that in 2011, some guidelines came out. So these have been coming out about every 6-7 years. And back then, this is what the guidelines would say. So if you have a clinical suspicion of EOE, you have to distinguish it from reflux. We didn't see that in the newer guidelines. We had to place them on 2 months of a proton pump inhibitor and then perform a biopsy. Okay, not immediately. So then you have to put them on this because you're trying to weed out the people who had reflux. So the assumption is that PPI would take care of all those who had reflux and it wouldn't have anything to do with the eosinophils. And then you get rid of all the reflux, because it's kind of hard. There's a gray line between how many eosinophils you have with reflux and how many you have with EOE. So if it normalized, you were dealing with reflux. If not, then you were dealing with EOE. So here are the assumptions that they were making, that people were making, is that reflux and EOE do not coexist. That the only action of PPI is to reduce gastric acid and thus protect the esophagus from peptic injury. So does it only do that, is the assumption. And that acid reflux has no contribution to EOE. And I just showed you in the last slide that maybe it does. Maybe it damages the barrier. And so reflux also is the only esophageal disease that responds to PPI. These are the assumptions. These have all been kind of taken out. So along the way, in about 2010, we started seeing a subset of people who had EOE that would respond to a PPI. So what are we dealing with? So these are EOE patients who actually they had symptoms similar to EOE. You go and biopsy them, they looked the same. If you took them off the PPI and you put them on steroids, that also helped. So it seemed anti-inflammatory. Who are these people? And so they called it PPI-REE. And then the conclusion was, after a time, that this actually was EOE, and that the PPI was helping it to get better from maybe some other reasons or ways. So now we don't have to do the 2 months anymore, because we're not distinguishing reflux from EOE, because the PPIs are actually a treatment. And how could that be? And so this is fascinating to me. So they took a culture dish of esophageal cells and were able to make a cell line with these. These are people who had EOE. They made a cell line. And then they were able to stimulate IL-4 and 13. If you remember, those are the signals that call in the eotaxin, which then calls in the eosinophils. And you see that portrayed here in this. So T cells responds, they make the IL-13, eotaxin comes, they call their buddies the eosinophils. Interestingly, this is no acid involved. You throw PPI into the culture dish, it stops calling the eotaxin. Very interesting. So it has nothing to do with acid. Now, acid might still be helpful because now you're still protecting the barrier. So now that actually PPI is a treatment for EOE, not just a way to rule out those. So going back to our guidelines then from 2025, let's talk about the clinical evidence of esophageal dysfunction. So if you're older, like say an older child or teenager or adults, this is how you usually get seen. Or this is a way, is that you come into the ER after just slamming down a steak. And so they usually do this about 10 o'clock at night while people eat then. And then they come into the ER about midnight, and that's when they call us. And so anyway, I guess people eat later, and usually if they've had trouble swallowing, they always you know that those guys want to get up in the middle of the night and come in. So, and you can already see on this case that this one has those lines. So dysphagia or slow swallows, or maybe even a fear that they would not be able to get something down. These might be some questions that you would ask. Heartburn or chest pain. And in one series in a small community like Roanoke, so 17 or almost half of patients who came in with a food infection had EOE. So that's older people, mostly dysphagia, food infections, kind of grade school. You might have other symptoms, more reflux-ish, vomiting, abdominal pain. And then when you talk about infants and younger children, very different. Not gaining weight, failure to thrive, failure to progress to solid foods, increased time needed for eating, food refusal. Sounds like feeding clinic. So I'm serious. And so this is something that is a helpful mnemonic that was in this journal article from about 5 years ago. And it's called IMPACT. So do they have to imbibe or drink more fluids to help something go down? These are questions to ask people that come in. Like they come in, I'm having trouble, you just hear winds of something happening, or they're not eating well. Do they dice up their food or puree it in order to eat? That's odd. Do they have prolonged meal times? Are they the last one at the table? Do they avoid hard foods or just eating altogether? Do they chew excessively to bring the food down to a small volume in order to even eat it? And then do they turn away even tablets or pills? So, we see a lot of kids who don't like to eat, now, still don't understand that, but a lot of times you take an autistic child or somebody has sensory issues, and they won't put the food into their mouth. But if you have a child who's putting the food, interested in food, and doesn't chews it up or spits it out after that, that's tuck that away, think about that. Or if they're chewing it up so much, or they're just like using their food like gum. And so, not always is that the case. My oldest son, we clocked a piece of steak for 45 minutes. It took us all the way from Southwest Roanoke to Bedford before he finally swallowed that piece. So you can't always take that, but most of the time, chewing for a long time could be an issue. So this is the case. I told you, I promised you that I was going to show you the 3 cases that I saw. And so this made me a believer in what I just told you. And so, because I had heard this, but hadn't really been going after these patients really aggressively because so many could be explained by other reasons. So this guy came to feeding clinic, autistic guy, very active, but had speech delay, moving around, and his parents were feeding everything in the bottle. So they dumped Pediatric, their baby food and everything, made this blend, and they were putting this stuff into a bottle, and that's what he was eating. And we did a barium swallow, we tried cyproheptadine to see if that would help. It only made him more hangry or agitated. And then, so I said, okay, let's check this out. And so you can see, this is what the scope looked like. You can see those lines. So this guy has EOE. So another patient that I saw in the same week came in, this guy is 13. And so for 4 years now, he's had a drop off in his weight. He became completely fearful of eating. He stopped eating. And of course, he has some delays also, so you can kind of write it off. And I think his primary care doctor, I think, kind of said, well, this is, he's got some issues with texture, and he does have all that. But you can see he choked on a Jolly Rancher, and then after that, he stopped eating altogether. And so he had severe malnutrition. We had to put in an NG tube. And then his scope actually wasn't that bad, but when we got the biopsies back, there were 60 eosinophils in high-powered field. And so in this case, because he had an NG tube, I was able to treat him with an elemental diet. I'll come back to treating with the diet in a minute to show you that elemental diet is highly successful, but most people can't hang with that. Okay, so we talked about endoscopic dysfunction, how to see these patients, how to recognize them. Okay, then what do we do next to make the diagnosis? We're going to scope them. So we're going to spend a little bit of time talking about what they look like visually, and then what they look like in the laboratory for the pathologist. And so these are some of the things that we see. And so you can see this over here, the EREFS, the EREF score. I must have messed up here. So the edema. So the edema means you lose, it's pale, and you lose the, you can't see the vascular markings. The rings are like this, and I showed you rings before, and you can get a scale of 3. It would be like that one that I showed you that had like that was so severe that it looked like a trachea. And then furrows, and you can see they're labeling some of these as more severe. And then exudates. So this is a mild exudate. Then you can see this is covering a good deal of the surface. So these EREF scores are recommended to note every time you do a scope, so that you can track these patients in time. And so this is, in this latest guideline, something that we should be doing. So this is just to show you kind of what a normal endoscope looks like. So you don't see those furrows, you don't see exudate, maybe a little something here, but you can kind of see the vascular markings here a little bit more. So EREF score, that's what it looks like visually. Then on biopsies, EOE has a patchy involvement. So you want to target those areas where you see findings, where you see the furrows, where you see the edema, where you might see a ring. And then it looks like 6 biopsies are recommended from 2 levels, 2 locations in the esophagus to increase your yield. And this is just a paper showing that as you increase your biopsy number, then you increase. I usually do 4 distally, 4 in the middle of the esophagus. Not that I'm right, but that's just seems to fit with the literature saying I don't need to do the last 2. Anyway, so this is I'm going to try to blow through this because this is getting a little specific or granular to it. But biopsy features go beyond just eosinophils. So there's a push for the pathologist to do more than just count eosinophils, but to look for some of these other features. And so there's an EOE histological scoring system that perhaps should be followed. And I've already talked to our pathologist who goes to my church, and he's like, oh, okay, send me the paper. So anyway, you can see the eosinophils in these red areas. So this is an increased count of those. And then this is the basal zone hyperplasia here by this line. And thirdly, remember the eosinophil makes fibrosis, makes it swell in there. And that's what you're seeing here back, where's my mom? Where are you? Back here in the lamina propria. So where this asterisk is in the increased pink is like fibrosis, and then there's some eosinophils back in here. And then you can barely see it, but there's some dilated spaces in between these. Up here is some surface layering of eosinophils is another thing. This is this keratotic epithelial cell over here in the middle. Then this is just some surface layer alterations, and then over here is a microabscess. So some very different things to follow histologically. Okay, so we've talked about what that looks like clinically, scoping, and then we want to just think about this is so these other things. And this is my only, like I was saying that things have changed in time. I have a feeling that in time this will sort of diminish. And this is why this field is so ripe for people who want to go research, because there's so many unanswered questions. And I don't know, none of these things, if you really think about it, look like EOE. When you get in there and you don't see these kind of changes, but they can cause eosinophils to be in your esophagus. And now through this end, not because it's listed in the guidelines, but you have to think endoscopically there are things also that can look like EOE. So here's something that looks like a ring, but this is a Schatzki's ring. So this is just a ring at the very distal esophagus that's common, seen with those who have hilar hernias and reflux. What can we do? And we're gonna spend some time on this, and please be thinking about any questions. Hopefully we'll have some time for that. And so these are, remember I mentioned proton pump inhibitor removed from being something that you wouldn't use in EOE as a way to distinguish EOE from reflux to now being a major player in treatment. You can also take steroids. So from the very beginning, back in the early 2000s, people started to try to see what was going on, thinking this was anti-inflammatory. You didn't want to keep people on systemic steroids. So is there some way we can put steroid on the esophagus like we would do eczema? We put cortisol cream or something on eczema. You would also want it in the esophagus. So how can we get steroids onto the esophagus? You saw in that first paper that dietary therapy was important, and how can we employ that today? And then recently, dupilumab came on the scene as the first FDA-approved medication for EOE. And then dilation. So dilations are really just to help symptoms. You don't cure EOE with that, but it is a way of treating. So proton pump inhibitors, we've already talked about that. The mode of action goes beyond just acid reduction. And then to kind of double down on its power to help patients is a study that was looking at a group that had omeprazole and a 4-food elimination diet, so dietary therapy and omeprazole compared to just omeprazole alone. And those who had omeprazole alone, they showed an average drop of eosinophils from 45 down into 12, which is really considered remission because 15 is the cutoff for diagnosing EOE. So PPIs alone are helpful. So as we go through each of these studies, or each of these modalities, I'm going to try to emphasize the percentage. You can kind of in your mind think, when I'm talking to patients or if they ask me questions, what is successful, what is helpful? So you can see in about 50 to 60%. So there's two responses, symptoms, and then what they look like, are they healing inside? Remember that one thing I mentioned that wiped out the eosinophils, took out the eosinophils, but they were still having symptoms. And there's actually, there's been other things. Reslizumab and mepolizumab have been tried. Those are also IL-5 receptor inhibitors, and they didn't work because they wiped out the eosinophils, but they didn't work. And Dr. Hart worked with one of those, was doing patients with that, and we found while you do a scope, and they had a histological response, but not a clinical one. So in PPI, you can see that a substantial number will get better, at least over half that you can tell families. And then we initiate therapy higher than what you normally would do. So twice the adult dose, or 1 mg per kg twice a day as opposed to once per day. And this approach showed a response in one paper recently that 53% responded compared to 10 to 12% with the daily dose. So you do that, repeat your endoscopy, and if they do well, you can actually dial them back to the daily dose. And about 80% will maintain remission after you do that. Those who responded should maintain. But as you know, there's a lot of concern for long-term PPI use, and I don't want to get involved in this because it's very complex, and a lot of this stuff is not formally proven, but there's been fears that long-term PPI use would be associated with bone mineralization defects, vitamin deficiencies, B12 deficiency. Magnesium is definitely interfered. The people will have low magnesium. There's been concern about kidney injury, very low strength to association with dementia, and then increased risk of infection has been seen in children. A paper done about pre-pandemic looked at about 18,000 patients over 10 years to see what kind of complications they would have with chronic use. And actually, this is only showed that C. diff infection was more common in those. But it's a complex issue. You want to, when we're talking about all 5 of these therapies or 4 of these therapies, share decision-making with these. And it's a conversation you have to have with each patient, and everyone comes at this very differently. The second area is swallowing the steroids. And I mentioned these other days. You can take Flovent and spray it and then swallow it. Or you can take Pulmicort, crack it open, and then mix it with something. Like here's a little, did my picture come? No, it didn't come in. But so 5 packets of Splenda mixed in with Pulmicort Respuel, you can make it into a jelly, or you can mix it with some of these household items like syrup, applesauce, chocolate pudding, or honey. None of this is standardized how you do it, but you take it after breakfast or supper, and supper, and then you can't eat anything for at least 30 minutes. Sometimes if patients can understand, I have them swish and spit so they don't get oral candidiasis, but you have to worry about that because will they swallow it? So remember, it was 50 to 60% for PPIs. This is 60 to 70%. Or this is the sort of the home brew mix of Pulmicort. So there's been some actually recently approved. So dupilumab was the first FDA approved medicine, but budesonide just recently came out with this stuff called, and I'm not supposed to put labels down, but I just wanted to show this to you. And the data behind this is that you use a high dose of this, 2 milligrams twice a day, and a 62% response. But FDA is only approved for 12 weeks. And so EOE is a chronic disorder. So after the 12 weeks, what do? So the way that this is helpful is it's a very easy, this looks like, like a mustard pack at a diner. And so you just peel it open and you put it into your mouth. It's much easier than trying to mix something with Splenda at home and then trying to take it down. The taste is much better. So you can actually get compliance over that 2-3 months rescope. If they're better, then budesonide is going to work, and then you can keep them on the home brew at that point. So that's how we're kind of using it. Now in Europe, there's this other agent, and this has an amazing response. And so it's not available here yet. And so you just put it in the mouth, it dissolves. And so we'll see what happens with that in time. So there might be some adverse reactions or effects, and I talked about candidiasis being a problem, and that definitely is. Adrenal suppression is seen, but is rare. So we have to kind of watch for that. And it seems to be less than you would worry about over time, but parents are going to ask about that. They don't want to have their child on topical corticosteroids. So maybe you could just do it for a few months and then stop it. Maybe that's the way you could do it. In fact, that's the way we used to do it, but long-term therapy seems to be necessary, and we'll go that in a minute. So dietary therapy, so we've had PPIs and now steroids, and then dietary therapy, there's 3 ways to do it. You can do allergy, you can try to see if allergy testing would help you to pinpoint which foods are there. We've already talked a little bit about elemental and in that early study. or maybe you can actually just take out foods that are commonly allergens. So skin testing or RAS testing or food allergy testing is not helpful. So when we first started learning about this, this is how we would manage things. We would bring people in, we would do an allergy test, and it would show nothing, zero. Well, we knew it was dietary allergen, so which one was it? So what do we do? Or it would show something like hazelnut or sesame. That's not, so what do we do with that? So is it take out sesame and they're going to be fixed? No, that didn't happen. And interestingly, if you look in the esophagi of patients, they're enriched in IgG4. Interestingly, they've actually, on a side note, milk IgG4 has been seen in one study to be upregulated. And IgG4 will downregulate an IgE response. So actually, it makes sense then that maybe this isn't an IgE-mediated thing altogether, so skin prick testing isn't going to help you. So maybe there's another way to do it. So you can do patch testing, and this is a way to look at things long-term. So you have to wear these for days, and then you get these wheels in the back on your back over time. Looks like fun. And then you come back, but it's not been standardized or validated, and it hasn't been helpful. But we tried to do this for a while, and then so it seems like testing directed isn't really recommended. So we also looked at elemental diet, and the quoted response is 94%. So compare that to some of the others, highly successful. And then you would have to add foods back every 8 to 12 weeks and repeat a scope. But in one series of adults, only 38% of them couldn't even keep up. This is adults, so you can imagine kids. They're not going to want to stay on an elemental diet. So it's really not useful unless you've run out of all other options or you have somebody who has a gastrostomy. Interestingly, the two that I mentioned earlier, they both went on elemental diet because they're not eating anything. So then in 2012, a group out of Chicago came up with, well, let's take the major antigens that cause food allergens and take them out and see what happens. So this is called the 6 food elimination diet, and I'm showing you the types of foods there: milk, wheat, soy, egg, peanut, seafood. And 70% achieved remission, and then most of them felt better. And this became a game changer, and so the way that the paradigm shifted from steroids and stuff, you could offer this to patients, take them off these foods, and then you would add one back, and then you wait, and then you rescope, and then you add another one back, and then you'd rescope, and then you'd add another one back, and then you'd rescope. And so that's 6 scopes or so to get to the bottom of that. Very intensive. But then they were done. Once you found what they were allergic to, then they could be done for time, and so there were some advantages there. And this is, so empiric diet is what's recommended now, but now people are thinking milk and wheat are the ones that have always been implicated as the most involved. So most people are looking at step-up diets rather than step-down, like I just showed you. And so this is a comparison between 1 food elimination diet versus 6. And so this is 129 patients. They took 6 weeks. And you can see that after 6 weeks of being on these diets, that the response is similar. And then they took the patients who failed and they offered them steroids or they offered them a 6 food, and you could see that you could actually buy back other patients. You could start off with a 1 food elimination, and then if they are failing that, you can offer them some of these other therapies at a time. And then it's a little bit less intensive. So milk, especially in children, seems to be the bad actor. So you could actually put people on milk restricted, and we're not talking about like, I'm taking out milk, but I'm still going to cook with it, or I'm going to have mac and cheese. You have to take it out. And so going back to this thing, you remember IL-4 and 13 were critical to causing the attraction of the eosinophil. And so dupilumab is a receptor antagonist to that. And so, so the initial study compared 300 milligrams weekly versus every other week, and then placebo. They showed that against placebo, 60% response versus 5. Remember, compare that to the others. And then in a later study, 102 younger children showed 68% response. So initially it was FDA approved for 12 and older, and now down to age 1, who are bigger than 15. So most recommendations say this is a step up after failure of other things, and insurance loves that line. So they'll come back and say, well, you haven't tried X or Y before you're allowed to have this. So that's all the medical therapy. So back in the 90s, when this first started, the adult GI people would go in, they'd see this problem, and all they would do is dilate and then get out of Dodge. They wouldn't even biopsy. They just, oh, you have a stricture, we're going to dilate you and get out. And that was actually the recommended treatment for a time. The dilation may be necessary, especially if you're just not eating, you're just not doing well. And it's another interesting thing is that just looking in with a scope, you actually might miss some of that thickness, you might miss some of those strictures that could be handled. So there's something called endoflip or functional luminal imaging probe that can be put in the esophagus and see distensibility of the esophagus, and you can actually see in real time if it's narrowed and maybe decide if you want to dilate. And a barium swallow, if you have time, is recommended for children for this very reason, to see if there's something, so you can actually make a plan before you do the endoscopy. And then sometimes just sliding down the esophagus to get that piece of meat will end up being a dilation. So you don't want to like go ripping away at this esophagus because it can tear really easily. So sometimes a mild dilation with anti-inflammatory therapy may be the case. And so I showed you so this is a tear, and you can see how deep this is and how that just makes your sphincter tone go right up when you see that after doing it. This is my case. This is a case during call last time. And so I thought this was her enchilada chicken, but because I didn't think that an ibuprofen tablet would cause this, but that's an ibuprofen tablet. That shows you how narrowed that is. And so I just kind of pushed him with the going after this guy, and he started moving on downstream, and I was happy. And I looked, oh look, I can see the EOE. I'll just take my biopsies, and boom. This is what I would do just by sliding my scope down to get that. And this was concerning. So I did a water-soluble contrast just to make sure that she was fine. But you can see that dilating is not for the weak of heart. So so over time, what's the natural history of this? Do they get better over time? Is it chronic? And how do we know this? So hopefully I can drive through this quickly. And then we know this from the placebo arms of some of these trials. So I mentioned the oral dispersible tablet. So they've looked at the trials of these. You can see that in one trial, it only took, with those who were on placebo, it took 87 days to have a relapse once they were off. So these are people that were already on some kind of therapy, and then they switched them to you're going to have the dispersible, and then how long until symptoms. Those who got the dispersible, it took over a year before they could see any kind of change. And then long-term steroids were looked at. So those who got placebo over a year versus those who got budesonide long-term to see the effect of long-term budesonide showed increased wall thickness and stiffness in those who were let go for a year. And this is key. Gaps in follow-up and care have been associated with fibrostenosis and difficulty of management, requiring more dilation therapy. So if you think about the esophagus being inflammatory, you can actually use medications for it, but over time it becomes a scar. You cannot use medicines, so all you can do is dilate it in time. So we want to avoid that. And this is seen here in this study, where this is looking at endoflip over time, and this is years of time without any kind of therapy. So years of time or symptom duration. And so this is distensibility on this side. So you can see in all of them, it's going down. So this is over decades of time without being cared for. You're going to be getting more and more symptoms, more and more difficulty with that. So what is the role of PCP then? So you can actually, this is very important because access to care to specialists is really restricted. And so these people fall away. They get lost to follow-up. And you'd hate to see these people showing up in a year or two later with their meat impactions. So the meat impaction I showed you was a guy that he liked pot roast. And so his family would have Saturday pot roast, and I'd see Stephen coming back. And so he was lost to care for years in between each time. And so it's very helpful for you to think about what are those, remember that impact thing? You could ask some of those questions. What's going on with you? How is it going? Have you been back to see the GI? Are you taking your medicines? Show me that you're taking your medicines. So very important. Also, when you recognize that somebody has this, start looking at nutritional factors. to get them in to see us early. And so endoscopy, unfortunately, is the only way that we can track these people to see how they're doing. There's no biomarkers. And so more and more centers are doing transnasal endoscopy. And so this, occurs with a need to cost outlay. Some of them are disposable endoscopes. So I found this picture online. So here's this guy. So they put VR goggles on them, and he's like putting this thing down her nose. And look at this room, by the way. I was just looking at this room, and I was like, are they in a hotel room? Or this does who's office? Who does procedures here? So anyway, this looks kind of set up. But if you can, I guess the point is that you can do this in the office in a procedure room if you have the critical stuff. And a lot of places are doing this and offering this. And so someone can come from rural retreat with their symptoms. You can slide down a transnasal endoscope and say, hey, you're flaring. Let's start working. You don't have to sign them up for it. And so I don't know what she's she's probably watching some kind of a Survivor show or something where she's in it. So then another way that you can do this, and how this is humane, I don't know, but is you can take this capsule and swallow it. It's tied to this string. Now, I'd rather have a scope than having some guy sitting there with a string. He pulls it back up, so it like goes into your stomach. The acid degloves this, and then you bring this sponge back. And then it's in its cytology and stuff. So give me a scope over that. But that's a lot of research centers are doing that.
It's like crab fishing.
Yes. Right. So, so here's your questions. So all the following are necessary except for which of the following. There could be more than one to make a diagnosis of EOE. Wes? Dark. No, I'm kidding. So what do y'all think? Wes is listening very nicely. So so what do y'all think? Y'all out. So you need esophageal dysfunction. You need to see the eosinophils. Weight loss is definitely seen, but not part of the diagnosis. It just helps you to know that somebody's having problems. So that's not it. You need to explore non-EOE causes. That's part of it. And remember, we talked about you don't need to have a dose of PPI anymore. So it would be A, B, D. On this one, I just briefly drove by this, but which of the following is a treatment for EOE? So D. These others have been tried and are being tried. So benralizumab, remember that's the thing that wipes out the eosinophils. That's an IL-5, IL-5, IL-5. This is IgE, and none of these work. So they do take away the eosinophils. And then your 13-year-old patient comes in with a choking incident with a cough drop. And so, maybe he just ate it too quickly, which a lot of kids do, so maybe you can just let him go. But what kind of questions would be helpful in asking that maybe increase your index of suspicion? So more than one. What'd you say?
B, D.
The history of asthma, remember atopic symptoms? C is kind of no. So they stopped eating hard things. Remember that's one of them. They modified their diet. Decreasing weight could be part of it. Family history, E, is important because remember family history is seen. So I get this a lot actually, where grandpa gets his esophagus stretched. Violent vomiting in the morning and need for hot showers. What is that? That's cannabinoid. So not this. So we have 30 seconds for questions, sorry. Typical for me. Yes, sir.
Two questions. You mentioned early on that the initial description was evaluating seeing furrows in the esophagus in kind of the initial description and discovery of this. You showed some criteria for the endoscopic grading that showed rings in the esophagus. Do furrows and rings imply any kind of specific phenotype?
No.
Differently?
No, you can have, trying to find your slide. So you can have something like that looks almost normal, and I showed you my case that looked almost normal. I was actually not I was glad that the biopsies came out higher to see that, but no, this is just indicative of the disorder. So it causes swelling and edema, and so the swelling is what's leading to those furrows.
And I know that TSLP is being studied for this. If you're doing transnasal endoscopy evaluation, you have someone who has EOE beginning to show regression after remission, wouldn't that be a great candidate for that kind of mechanism of stopping upstream inflammation starting the EOE?
Certainly, there's multiple things being looked at as targets. I didn't see any. In any of the things I saw that was something that they were looking at, like a monoclonal to that. Any other thoughts? Questions, complaints? Okay.